As Sue said, I'm Judith. I work at Counties in the area of antenatal HIV and fetal medicine. The two roles sit together really nicely because they're both about screening, and certainly for both areas, if you do get a diagnosis of HIV or that something's wrong with your baby, it can be equally devastating. Just to give you some history on HIV and where we are at, in 2008, the Ministry of Education, well, not Education, Ministry of Health. Can tell I've got school kids. They thought it was important that we moved away from risk-based assessment to universal screening. And so a lot of resources were put into educating health professionals on how they should talk to their women about the screening test and what we would do if somebody had a reactive result. The reality has been that people have adopted this practice, but that we haven't had as many cases as what was anticipated. As a result, the Ministry of Health removed funding for there to be a specialised midwife in every DHB, and then it became up to the DHBs whether or not they kept someone in that role. I've been really fortunate that in Counties they have felt that it's valuable, and so it's good in that if you do need some education in your practice or you have somebody that has a reactive result, there's a dedicated person that can talk you through what to do next. I think the thing that is also relevant with HIV not being seen that much in New Zealand is that, firstly, people are scared by it because we don't really come across it, so we're not used to dealing with it. And there is still a definite element of stigma. So anything that we do when we're talking about this kind of virus, I like to think that maybe we're helping with the stigmatisation or reducing it. The AIDS Epidemiology Group have released some data that I'm going to share with you. So it's interesting to note that of the 224 cases that were diagnosed in New Zealand last year, it still is an issue with men, but there were 18 women. So let me tell you what was special about those women. The means of infection is mainly through heterosexual relationships. And look at the age range. These women were diagnosed between the ages of 20 and 40 as the bulk of them. Now that's diagnosis, that's not even infection. So what that tells me as a practitioner is that we now have a group of women in a childbearing age range in heterosexual relationships that are at risk for HIV. When the ministry rolled out the universal screening, these were the main aims. We know that with treatment, we can reduce the mother-to-child transmission to less than 1%. When we do nothing, it can be as high as 30%. So why wouldn't you be looking for it? The other thing is that when women find out they have the infection, they can start on treatment. Last year, I was with one woman that found out for the first time in her pregnancy that she was infected with HIV. And the message that came from the infectious diseases physician was, you will be well and your baby will be well. And that's because we've discovered it and we're going to get you on some treatment. It's not the death sentence that it used to be. People are now living with HIV. So how are we going in regards to this mother-to-child transmission? We thought that we would reduce the infection rate to less than 1%. But in actual fact, there have been no cases since we have been screening, detecting and treating. That's good. And we do have to keep it in the forefront of our mind because there were 6 women last year that gave birth to babies that had HIV, and 3 of them found out for the first time in their pregnancy that they had the infection, and they only found that out because we did screening. If we hadn't done the screening, that would have been 3 children that had a 30% chance of contracting the virus. The Ministry of Health stipulate that everybody should be offered the test. And because it's a test that you can decline, it's really important that we're documenting that. One of the Positive Women update days that I went to, they're run every year and they're free, I can really recommend them. There was a woman there who had given birth to her baby just before screening was on offer. And then she found out that she had the infection and that her child did as well. And she cried. She just knew that her life would have been so different if she had been offered that screening. So we need to document that we're offering it or when people are declining. I've just had an audit result come through for a lab test. Now this is specific to practitioners who are ordering tests within the counties region and where the woman has the bleed at lab tests. So 5,675 women went for those first antenatal bloods, and there's been 9% that didn't have the HIV test added to the request form. So it seems that for some practitioners, they're still needing to get the message of the value of this testing. And I guess that's why my role is so important. The red flag. Min talked this morning about STIs. She mentioned that syphilis is increasing, and the Auckland Regional Sexual Health Service have shown statistics that between 2013 and 2014, cases of syphilis are doubling. So the red flag is all about STIs. If you've got somebody with a history of STIs or a current STI, especially the ones that we don't see so often like syphilis, gonorrhea, remember that you should be ordering HIV testing as well. What we're recommending at counties where we get a large number of women that come through with having had no antenatal care is that if they have a screening test and it comes back positive or reactive, we don't always have time if they're in labour to go on and do a viral load, but if we have that history of STIs, then we instruct our staff to presume that they are HIV positive and to start the antiretrovirals in labour. What happens when you get a reactive result? Have we got anybody in the audience here that's had to deal with this? Yeah, a few. It's a really sensitive test. And so what can trigger a reactive result might be something as simple as a woman having had any virus. And so it's always important to reassure the woman that the initial reactive result is not meaning a positive diagnosis. You organise a viral load, and it's the viral load and the Western blot test that give you your diagnosis. The good thing with the system that's in place is that the laboratory will let you know, so you're not going to miss that result, and they'll also let me know if the bleed has taken place within the county's region. Then I will make sure that you know what to do next, and basically what we're both doing is we're calling the HIV team at Auckland, and they will send somebody out to support you. You must always give the result, obviously, face-to-face. I don't think any of us would do this over the phone. But the nice thing is that you'll have a specialist there who will either support you to give the news, or they will give the news themselves while you all sit there and support the woman. Sorry, this thing's got a mind of its own. Then they go through to Auckland Hospital and meet with the infectious diseases team, start medication, and their pregnancy care is taken over by Auckland Hospital. So that's HIV. As part of screening, I also wanted to talk about maternal serum screen 1 and 2. Traditionally, it's always been known as the screening test looking for chromosome problems like Down syndrome and other conditions. But can I just say that it's so much more than a screening tool for Down syndrome? And I think when it comes to screening, it has a lot to do with how we sell the test. This is time-consuming stuff, and for a lot of our population, especially if their health literacy is not so good, they don't really know what we're talking about when we say Down syndrome. So I often phrase the test as saying there are screening tests available that can give us more information about the health of your baby and your pregnancy. Yes, we're going to pick up a likelihood for chromosome conditions, the common ones. Neural tube defects. The nuchal test is excellent at predicting heart abnormalities, but the analytes that we can pick up in the blood test can be a predictor for preeclampsia, growth restriction, and these are all things that we can do something about. One thing that we also find in a fetal medicine setting is that if the woman is likely to have a cerclage, so you've got somebody with a history of previous second trimester loss, then it's really important that we have a screening result before we put a suture in. The last thing we want to do is lock in a pregnancy that we then find is abnormal. For MCDA twins, a discordancy with the nuchal at 12 weeks can be a predictor for problems, twin-to-twin transfusion, or possibly even the heart defects. So really important in situations like that. Sue showed you the package with all the different resources in it, and this one is really good. The thing that I like about this resource is it's got a picture of a child with Down syndrome in it, and for a lot of people, especially if English is not their first language, they need to actually see a picture of someone with Down syndrome to truly understand what it is that we're screening for. We've already had a look at some of the time factors where testing is important, and we've had speakers talk about that how early engagement is so important in being able to get these tests at the right time. And so although you have got a time frame to organise the test, there are certain gestations when the results are likely to be more accurate. For the bloods in MSS1, they're going to be most accurate at 10 weeks. For your nuchal, that's going to be most accurate at 12. And for MSS2, most accurate between 14 and 18 weeks. Saying that, better to have screening than not to have it at all. What happens when you get an increased risk result? We're trying to change our language a little bit now, and we say increased chance. And even that concept of 1 in 300 can be really difficult for our women to understand. They think that it's a diagnostic test sometimes when they come and see us, and that it means their baby has got a chromosome problem. I have a jar of coloured beads in our office. I have 199 pink beads. It took a while to count them out, and one of a different colour. And I use that as an example to try and show women what it means when your risk is 1 in 200. Renuka, my colleague, explains it so beautifully. You might really not like that one green bead that's sitting there amongst the pink, and you feel like you have to find out and do more about it. Or you might think, hey, there's just so many pink in there, I'm not hardly seeing the green at all. So we have to be really innovative with the way that we explain these tests to our women and help them to make decisions about what next. I'm sure you're all familiar with the form. There's lots of information that we have to put on it. The more information, the best, because it all goes into a computer program, and that's how the risk is generated. So if you get any of the details wrong, it can affect the way that the result is calculated. So if more information comes to light, you realise that she has been smoking or that it's now a twin pregnancy, you can phone up the screening unit and ask for the risk to be recalculated. Maternal serum screen 1 with all the analytes just to let you know that we do have a standardised letter that we use in fetal medicine, so if you're having trouble trying to work out what the results mean and what you should be doing about them, just give us a call. There's even more analytes to interpret with maternal serum screen too. The good news is there are things that you can do if the baby is likely to be growth restricted or your woman is more likely to have preeclampsia. The other thing that's quite new is the procedure-related loss. If you have got somebody that wants to go on and have invasive testing, we have always quoted a loss rate of 1 to 2 in 200. But latest research has come out with a meta-analysis that suggests it could be much lower. Jeepers. 1 in 500 for CVS and about 1 in 1,000 for amnio. These statistics haven't been widely incorporated into the literature, but just to be aware that this change might mean that invasive tests are now more acceptable to women if they know they're not risking miscarriage. And finally, the can of worms. I know it feels like when we're screening that sometimes we are opening a can of worms. It's time-consuming, but when we get it right, especially when there's something that can be done as a result of finding out somebody has HIV or they're more at risk of having preeclampsia or a small baby, then we should do it. The other thing that we see a lot in fetal medicine is that gestation really matters. And if you find out earlier on in the pregnancy that there's something wrong with your baby, you have so many more choices. So let's open the can of worms and make things better for our ladies.